Okay. Good evening, dear colleagues. I'm Dr. Irene Akidino, Chair of the Education Committee of the Intensive and Critical Care Society of Nigeria, also the Vice President of the Society. It's my pleasure to welcome you all to our 29th edition of our bi-monthly webinar series. It's going to be very, very interesting. Renal replacement therapy in the ICU. One of the major things that we do in the ICU. Next, I will hand over to the president of the society, Dr. Job Otokwala, to give his welcome remarks. Thank you very much. Mr. President, over to you, sir.
Good evening, highly valued colleagues. I want to welcome Dr. Sodhi, who has taken up this initiative to talk to us today. I want to welcome everyone, those in the Intensive Care Society of Nigeria as members, and then our colleagues from other societies. Today, we have an interesting topic, renal replacement therapy, with all those who participate. So I implore everyone to listen very attentively. This is our webinar series number 29. And then we have, I'm sure the speaker has a lot to share with us. And everything we will learn tonight will actually assist us in strengthening our knowledge base to practice well for our patients as well, and to get better outcome. We all know that patients who require renal replacement therapy in intensive care units are those who are daily in need of this knowledge. So thank you very much. Welcome everyone. This platform. May we gently mute our phones, enable us learn maximally. So at the end of the day, we have enough knowledge to strengthen our practice. Thank you, our program.
Thank you, Mr. President. I will hand over now to the moderator, Dr. Kate Edionhon, consultant intensivist and anesthetist at the Cedar Crest Hospital and head of the ICU department. She will moderate this session. Over to you, Dr. Kate Edionhon. Thank you very much.
Good evening, everyone. I'm Dr. Kate Edionhon, as she has introduced. We're going to have a good time together listening to our guest speaker, Dr. Kanwalpreet Sodhi. Without wasting further time, I'll quickly give a citation on Dr. Kanwalpreet Sodhi. Dr. Kanwalpreet Sodhi is a distinguished Indian specialist in critical care medicine, an academician, a researcher, and a teacher with more than 2 decades of experience in intensive care practice and also in education and clinical research. She currently serves as the director and head of the Department of Critical Care at Deep Hospital, Ludhiana, India. She holds postgraduate diploma and fellowship in anesthesiology, intensive care medicine, neurocritical care, and critical care education from India and Europe. She has diploma in anesthesia, Indian diploma in critical care medicine, European diploma in intensive care, and fellowship in neurocritical care. Dr. Sodhi is an accredited teacher for Doctorate of National Board Training in Critical Care Medicine, and she is also recognized as a teacher and examiner for postgraduate critical care courses by the Indian Society of Critical Care Medicine. In addition, she is certified as an instructor in basic life support and advanced cardiac life support by both the American Heart Society, by both the American Heart Association and the Indian Resuscitation Council. She's also an instructor for the Fundamental Critical Care Support course conducted by the Society of Critical Care Medicine. She has played a major leadership role in advancing critical care medicine in India through several important positions in the Indian Society of Critical Care Medicine, including being the current Vice President of the Indian Society of Critical Care Medicine. She is also the coordinator of the Research Committee, chairperson of the Nephrology Working Group, and National Executive Committee member. She was also nominated by the Ministry of Health, Government of India, to serve on the Technical Resource Group responsible for developing national guidelines on intensive care unit admission, discharge, organ donation, and end-of-life care. An accomplished researcher and editor, Dr. Sodhi has authored and co-authored numerous scientific publications in national and international index journals. Our major areas of interest include renal replacement therapy, extracorporeal membrane oxygenation, airway management, mechanical ventilation, infection control, sepsis, neurocritical care, and intensive care outcome. She has served on the editorial boards of reputed journals, including the Indian Journal of Critical Care Medicine and Journal of Anesthesiology Clinical Pharmacology. She has more than 40 original research papers in in-depth journals and over 50 chapters in textbooks of critical care medicine and anesthesiology. Dr. Sodhi is widely recognized for her contributions to patient safety, critical care education, protocol-based intensive care management, and multidisciplinary intensive care practice. She has received several national honors and presidential citations from the Indian Society of Critical Care Medicine for her outstanding service, academic contributions, and leadership in critical care medicine. Dr. Sodhi, welcome, ma. Please put our hands together for her. You're welcome, Dr. Sodhi. Thank you for taking the responsibility to talk to us about renal replacement therapy in the ICU.
Thank you, Dr. Kate, for the introduction. And I'm humbled to be invited by the Intensive and Critical Care Society of Nigeria for this talk. It's an honor and a pleasure for me to represent the Indian Society of Critical Care Medicine on this forum. Thank you, Aaron, and thank you, Kate, and thank you, President Mr. Job. So I'll share my slides, and I'm here to talk about the renal replacement therapy in ICU. So I hope my slides are visible.
Yes, they are.
Yes,
they are.
it's visible. Yes.
I'm sorry, but I can't see. Are they visible?
Yes, they're visible.
Okay. So good evening, everyone, and I welcome you to this session on renal replacement therapy in ICU. I would be basically highlighting where we need renal replacement therapy in the ICU, how to decide the modalities, and a lot many other things. The technical aspects we can just discuss, but I have tried to focus on how we decide the renal replacement therapy in the ICUs in current scenario. So globally, we all know about 20% of the hospitalized patients and more than 40% of ICU population, they have AKI mostly as a part of the multi-organ dysfunction syndrome. And of these, more than 50% require renal replacement therapy at some point of time, which certainly represents a substantial escalation in the complexity and cost of care associated with increased morbidity, mortality risks, and also poor renal outcomes, including long-term dialysis needs. So most important thing is that the clinical decision-making related to RRT initiation for patients in AKI in the ICUs is not actually standardized. There are many RRT dilemmas we have, like when to start, which mode to select, how long to continue, and when to stop. So in the next 30-40 minutes, I'll try to cover these aspects of the RRT, and let's go back a bit clearer on how we go with the renal replacement therapy. So initiating RRT in ICU can be mainly because of the removal of waste products, the restoration of acid-base balance, correction of the electrolyte abnormalities. Fluid balance is another thing which is handled by the renal replacement therapy, nutritional support, and sometimes for removal or modulation of the septic mediators in our sepsis population. But whenever we start with a renal replacement therapy, there are certain goals of renal replacement therapy we always should have in mind. And primary of this is to avoid the intradialytic complications, especially hypotension, decreasing the ICU length of stay, decreasing the mortality, and certainly improving the renal outcomes and decrease the need for long-term dialysis in this population. So the optimal timing of dialysis actually is not defined. The KDIGO says for any life-threatening changes in fluid, electrolytes, or the acid-base balance, we should start RRT emergently, or in other broader clinical context conditions, there we can always wait. So if at all there are absolute indications, like what are the absolute indications? Might be the refractory hyperkalemia, refractory acidemia, refractory volume overload, or the uremic signs symptoms including bleeding, pericarditis, encephalopathy, or in dialyzable toxin ingestions. So we always have to immediately start the renal replacement therapy. There is no controversy regarding this. But if at all we have the relative or the non-emergent indications, which can be in the form of oliguria or anuria, the azotemia, which we routinely see in our ICU population, hypermagnesemia, or the conditions like tumor lysis syndrome or rhabdomyolysis, and the non-renal indications, which might include sepsis, or wherein we have to remove the cytokines. There's an increased intracranial pressure, like in traumatic brain injury or in acute liver failure patients, or patients with ARDS, where we are thinking about renal replacement therapy. Therein, it's always a wait and watch policy. But what does this actually means? So this means we can start with early versus late. So what is actually early in certain contexts might be late in the other. And the studies which have the major landmark trials which have studied the timing of initiation of RRT actually also have the arbitrary cutoffs for all the parameters for wherein we start with renal replacement therapy. So there's lots of controversy surrounding this. So early might be related, we might have good optimization of volume status, early correction of the acid-base balance and the electrolyte disturbances. We can have control of azotemia too rapidly, but it might be sometimes associated with the complications, which may be related to the vascular complications per se, or the risk of iatrogenic complications, which can actually be avoided with the late initiation of renal replacement therapy. Actually, most of the studies have seen that when we start RRT late, there can be actual avoidance of RRT per se. So these are the major landmark trials which studied the timing of initiation of dialysis in acute kidney injury. And of all these trials, the ELLEN, AKIKI, IDEAL-ICU, START-AKI, or the AKIKI-2, except for the ELLEN trial, which was a single-center trial largely targeting the surgical patients, which showed that early renal replacement therapy is beneficial and showing significant mortality benefit of 39% vis-a-vis 54% for late initiation of RRT. None of the other trials have actually shown any difference when we compared the early versus late. So the controversy actually continues. And what was the major thing was that in delayed RRT, fewer population needed renal replacement therapy per se. So if we talk about timing, it is all about the precision. Early versus late does not make a difference, and optimal timing still remains clear. What we need to have in mind is that starting early or late does not affect the outcomes, but actually with late RRT, we can avoid renal replacement therapy itself. So talking about the modalities of renal replacement therapy, most of the modalities, they are divided based upon the duration of therapy. So we have the continuous therapies, wherein we routinely talk about the continuous renal replacement therapy, where we deliver the renal replacement therapy continuously for around 24 hours a day, 24/7, the CRRT runs. But we ought to forget the peritoneal dialysis also, which is actually also a continuous therapy. And we'll be, in the later half, we'll be talking about the benefits of peritoneal dialysis also. So, which is a very good modality, especially for the resource limited settings. And then we have the intermittent therapies, which can be prolonged intermittent renal replacement therapy, or what we term as SLID, the slow, low efficiency dialysis, wherein longer treatments, typically sessions of 6 to 12 hours, but we may sometimes extend up to 18 hours are performed, and they may be varying from daily to 3 to 7 days a week. And the intermittent hemodialysis, which is the conventional hemodialysis, delivered in sessions of around 3 to 6 hours, performed from 3 to 7 days a week. And further, all these modalities are further divided basically depending upon the modality of solute removal, what mechanism we are using for solute removals. Primarily, two mechanisms of solute removal are important, which are used for the renal replacement therapy. The first is the diffusion, wherein the solutes actually they are cleared from higher concentration to a low concentration, and based upon this concentration through when they pass through a semi-permeable membrane, the solutes are cleared. So all the modalities, the hemodialysis primarily uses the diffusion based solute removal, and only the small molecules, they are removed by diffusion. But the other modality is the convection, wherein a positive hydrostatic pressure applied on the blood side, it leads on to a solvent drag, wherein the solutes, they actually move along with the solvent. So water and solutes move together, and which are removed out through a filtrate. So this also this modality, along with the small molecules, it also leads on to removal of the middle molecules. So this is a very important modality when we talk about the convection in hemofiltration, wherein targeting the septic molecules, the cytokines, they are easily removed by the convection. So diffusion based therapy are the dialysis, and hemofiltration is a convection based therapy. So talking about all these modalities one by one, intermittent hemodialysis, we all know, dialyzing with a higher flow rates than the CRRT, and the typical flow rates are in the range of around 300 to 500 mils per minute, and regime targeting 3 to 5 hours of dialysis around 3 times a week, but we can have more frequently in the ICUs. So higher rate and rapid falls in plasma osmolality means it is only suitable for patients who are cardiovascular stable. So hemodynamic stability is a must for intermittent hemodialysis, and it routinely forms basis of long-term RRT, but not often very used in critical care settings, but we'll be talking about wherein we use the intermittent hemodialysis. So advantages, we all know, it's inexpensive, flexible timing, rapid correction of both the toxins, the solutes, fluid, they all are corrected very fast, and we can go ahead with minimal anticoagulation exposure. But there are issues with intermittent hemodialysis, primarily the systemic hypotension, line-related complications, or if there is rapid correction of the osmolality, the seizures or dialysis disequilibrium occurs, or we can have the delays in renal recovery, which we'll be talking about. CRRT involves filtering or dialyzing continuously 24/7, but we need to have dedicated machines, dedicated staff, and lots of fluids and other expensive things, which leads on to more expenses for CRRT, and it requires continuous anticoagulation. But since the middle molecules are largely removed, so sepsis, cardiovascular instability, or head injury, or acute liver failure patients, the CRRT is certainly superior to IHT. And most of the RCTs comparing IHT with CRRT have shown no major survival difference when we compared CRRT versus intermittent hemodialysis. So the different modalities of CRRT based upon the mechanism of solute removal, it is continuous veno-venous hemodialysis, where diffusion is the primary mechanism and we achieve small molecule clearance. Then we can have the continuous veno-venous hemofiltration, wherein we are using the convection-based therapy and we can achieve small, medium, and some large molecule clearance along with the fluids. And then we have a combination of continuous veno-venous hemodiafiltration, where a combination of diffusion and convection are used for clearance. And then we have the scuff, wherein the primary goal is only patient removal of the fluids. So advantages of CRRT, certainly hemodynamic stability and better renal recovery. We have the stable and predictable volume control, stable and predictable chemistry control is there, and the ICP is much better maintained. And certainly we can modify the cytokine removals with the convection-based therapy. But the major issues with continuous renal replacement therapy is, before even cost, I will say the availability of the machines, especially in the uh, uh, low resource settings. And costs is another major issue. We have limited mobility since this machine runs continuously 24/7, and the solute removal is not that rapid. It is a slower removal, and we need to have stringent anticoagulation with CRRT. SLED or PIRRT, that is the prolonged intermittent renal replacement therapy. This is a hybrid therapy combining the logistic and cost advantages of intermittent hemodialysis with the relative cardiovascular stability as seen with continuous renal replacement therapy. And the major advantage is its flexibility in terms of intensity and duration both, wherein we can actually use the routine dialysis machines by using a reduced blood flow rates, which we keep around 150 to 250 mils per minute, and we can have longer hours at a lower efficiency as compared to other modalities. So advantages are that it is a flexible, can be performed with conventional dialysis machine, requires lesser training, no startup, so lesser cost, less anticoagulation requirements. We can actually go ahead with simple saline flushes and with no anticoagulation as we can do with the intermittent hemodialysis. And the adequacy is similar to CRRT, and the hemodynamics are as good maintained. So the meta-analysis also have shown that SLED has similar outcomes when compared to continuous renal replacement therapy. Then another modality we always talk about is the SCUF, which is the slow continuous ultrafiltration. Ultrafiltration actually also uses the convection. It's a convection-based therapy wherein only the fluid is removed. No solute drag is there. So this is a gentle 24-hour CRRT designed specifically to remove the excess fluid in particular patients with heart failure resistant to diuretics. So primarily it treats the fluid overload, especially for patients who do not require extensive solute removal or toxin clearance, the patients with refractory heart failure. So this does not remove the solutes or urea, but it is especially useful for removing the fluid, especially and very useful for hemodynamically unstable patients. Then coming on to peritoneal dialysis. This was thought to be a home-based RRT primarily for end-stage renal diseases, but lately it has been accepted as a form of renal replacement therapy, rather a continuous RRT for patients in AKI in resource-limited settings, wherein we only use the peritoneal lining to filter the blood. So even the meta-analysis, including a Cochrane review, has shown that PD is non-inferior to other extracorporeal modalities in AKI, and ISPD guidelines have been given for peritoneal dialysis in AKI in 2020. And I think we all should go back and go through this article. This is a wonderful guidelines for AKI. So in peritoneal dialysis, what we need to have is we need to have a access, which routinely is with a Tanco catheter, which is pretty flexible, and we need to have a peritoneal fluid, that's the dialysate fluid, which we need to fill. And then we need to give a dwell time wherein this fluid remains, and the exchange of the solutes, it occurs through the peritoneal membrane, and ultimately this is drained, wherein the solutes are removed in this drain. So this is a very simple procedure, and multiple modalities of PD are available. But what is primarily used in the ICU population is the automated peritoneal dialysis, wherein a cycler is used to perform the exchanges typically in the ICUs, and it can be given a dwell time, and the amount of fluid is which we give is fixed, and we can have good solute removal. And it does not need much of the technical things. So this is preferably preferred where we have systemic anticoagulation contraindicated. We have some excess related issues are there if we do not have a vascular excess. So it is very useful, and it is especially good for hemodynamically unstable patients in resource limited settings. But the concern is that we need to have a good peritoneal membrane. There should not be any issue with the peritoneal membrane, no peritonitis, no abdominal procedures. And even in patients with severe respiratory failure or pulmonary edema, wherein we can have some issues because of the fluid collected in the peritoneal membrane, so we can have issues with the PD. So comparing all the therapies which we discussed, the continuous versus intermittent therapies, primarily the solute transport principle is different in continuous veno-venous hemodialysis. This diffusion, in hemofiltration, convection is the major solute transport principle. While when we talk about the hemodialysis, the continuous veno-venous hemodialysis or the SLED or intermittent hemodialysis, herein the diffusion is the primary modality and we can target only the small molecules. Then the blood flow rates set are lower in the continuous therapies as compared to intermittent hemodialysis, but in SLED we can keep the intermediate blood flow rates. And also what is seen is urea clearance is much faster with intermittent hemodialysis as compared to continuous therapies. The SLED achieves also a good clearance, but the clearance of small molecules with continuous therapies is much less. So let's see what the literature says. When we compare the CRRT versus IHT, all the solute clearance is much smoother with the continuous veno-venous hemodialysis as compared to intermittent hemodialysis. This red line shows the IHT, while blue line is for the continuous veno-venous hemodialysis. So the the bicarbonates are better removed with continuous veno-venous hemodialysis, and the blood pressures are better maintained with the continuous therapies. We all are aware of this. So this kinetic modeling of urea clearance, it showed that when we have the intermittent therapies, there is lots of seesaw pattern was seen with the clearance. But with continuous therapy, the clearance was much smoother and consistent. So certainly for solute clearance, better removal with CRRT, but slower. When we talk about the fluid overload, again, we know that with intermittent therapies, the rapid fluid removal does not actually allow for plasma refill. So lots of hemodynamic instability can occur. But when we have slower removal with CRRT, so it is preferable for the hemodynamically unstable patients. So again, fluid removal, we can have more precise fluid removal with CRRT as compared to IHT. And many studies have clearly shown that we can achieve precision fluid management with CRRT. When we talk about RRT, we always think about the long-term renal outcomes. And many studies have clearly shown that when we compare the IHD with CRRT, the renal dependence, the renal outcomes are much better. The renal recovery is much better with the CRRT as compared to IHD, although there is no mortality difference. So we must keep in mind that beyond the mortality, we also have to talk about, also have to think about rather the long-term outcomes. So they are much better with CRRT. And not only the single center studies or the RCTs, but the systematic analysis also show that there is decreased dialysis dependence and better complete recovery, renal recovery seen with continuous renal replacement therapies as compared to intermittent hemodialysis. The other thing which comes into mind is cost. So when we talk about CRRT and IHT, we always talk about the short-term cost. We always say that IHT is much cost effective, but many studies have clearly compared the long-term costs. And this one of the good economic analysis wherein 5 years total cost of patient, that the patient remained on RRT, and it was shown that despite higher upfront cost for CRRT, which was in the range of $4,046 for CRRT vis-a-vis around 1/3 for intermittent renal replacement therapy. The 5-year total cost, including the cost of dialysis dependence, was lower with CRRT, which amounted to $37,000 for CRRT versus $39,000 for intermittent renal replacement therapy. So we must keep in mind the long-term dialysis dependence and long-term costs. Again, systematic analysis of 49 studies, again, when they showed the economical analysis, they showed that initial CRRT is cost effective when costs of long-term dialysis dependence were considered. So the long-term cost of AKI may be lower initially treated with CRRT compared to those treated with intermittent hemodialysis. So please do consider this long-term cost. So ultimately, when we compare the CRRT versus IHT, CRRT has better maintenance of hemodynamic stability, better prevention of surges and intracranial pressures, therefore useful in the neurosurgical and acute liver failure population, effective in clearance of middle molecules, which we have been discussing, and certainly so good for sepsis patients, permits adequate nutritional support and fluid maintenance, so better renal outcomes and ultimately cost effective, which we have just talked about. But certainly intermittent hemodialysis is more practical, flexibility is there, the patient is mobile, same machines can be used as we routinely use in our dialysis units, and said to be less expensive, although I do not agree with that. But certainly lesser anticoagulation requirements, so thereby fewer bleeding complications and rapid solute clearance. I'll not say superior, but it is more rapid solute clearance is an advantage. So the considerable debate regarding which modality is most appropriate, this continues, and current data does not suggest that any individual modality of RRT provides better patient survival, but certainly CRRT has better recovery of kidney function. So modalities should be actually complementary and must not be considered as mutually exclusive. So now the thing that comes into our mind is how we decide which modality to initiate. If all the modalities are same, so which one to initiate? So there are many factors, including the patient-specific factors, clinician-specific factors, where there are the clinician goals of therapy that he or she has in mind, the relative indications, and the organizational, the infrastructure-related factors which influence the decision. So we'll be discussing how we decide. So if we talk about, we say no single RRT technique offers a survival benefit. So the decision will primarily depend upon the fluid and hemodynamic status of the patient. Then what actually we want to remove from the plasma, the mobility considerations, the cost considerations, the available resources and clinical expertise, and long-term renal outcomes. So let's discuss what we want to remove. This is one thing when I talk to my residents, I always say that this is the primary thing which we should have in mind before deciding which therapy we are going for. So if we're targeting the small molecules, including the routine urea, creatinine, or the electrolytes, then we can go in for diffusion-based therapies, and dialysis or filtration, anything can be used. But if we are targeting the middle molecules with a molecular size of around 500 to 5,000 Daltons, filtration is certainly a better modality than dialysis. So because the convection clears the middle molecules better. And then again, for low molecular weight substances, especially the cytokines or the complements, the immunomodulators in sepsis, here again, only filtration is going to remove these molecules. And for water, filtration is certainly better than dialysis. Then comes the indication. So what is the clinical condition for which we are going for the renal replacement therapy? So if we have sepsis, we have acute brain injury, fulminant hepatic failure, or we are targeting the nutrition management or adequate fluid management, then certainly continuous renal replacement therapy is a good choice. But if we are targeting the electrolyte management, so we can use both intermittent hemodialysis or the continuous veno-venous hemodialysis. But again, for the electrolytes like potassium or calcium, IHT certainly achieves more rapid correction and is the preferred modality, but CRRT can also provide effective but a slower control. But what if we are targeting sodium? then I would not prefer intermittent hemodialysis. We have to go in for continuous renal replacement therapy, which will achieve a slower, more controlled correction of sodium and thereby avoiding the neurological sequelae of osmotic demyelination syndrome. Then if we have only fluid removal in mind, then scuff is a good option, although we can have ultrafiltration with both IHD or SLED also. But if we want to remove the myoglobin, supposedly, so then again, it is a middle molecule. So IHD is not going to help here. So we have to go in for continuous renal replacement therapy. Then what about toxin removal? We talked about that there is rapid clearance with intermittent hemodialysis. So thereby, this is the preferred modality for then continuous renal replacement therapy, even in hemodynamically unstable patients. But not all toxins are removed. So we can have the low molecular weight toxins, which can be easily removed by the hemodialysis. Then what about the patient status? If the cardiovascular stable patient is there, we can go in for any modality, we just discussed. But what if hemodynamics are unstable? So we have to go in for continuous renal replacement therapy. But what if CRRT is not available? We can go in for peritoneal dialysis, or else even we can go in for SLED or intermittent hemodialysis with slight modification of the standard prescriptions, wherein we can have more prolonged treatment time. Slower blood flow rates do help, but not in a major fashion, because what we routinely think is that slower we decrease the blood flow rates, we'll have more better hemodynamic control. But more important is the prolongation of treatment time. Also, we can use higher dialysate sodium concentrations and the decrease in the dialysate temperatures. They all can help us achieve better hemodynamic stability with SLED or IHT. What about the coagulation profile? The second thing we have to look in the patient is the coagulation profile. So if there's a normal coagulation, we can go in with any modality. But what if the coagulation is deranged? We can go in for peritoneal dialysis. We can actually prefer peritoneal dialysis, or even with IHD or SLED, we can go without coagulation at all. The other thing which affects the decision making is the resources, the availability of equipment, the manpower, clinicians' experience, and cost. So we all know that CRRT is more labor intensive, more expensive, and hampers the patient movements, unlike the intermittent hemodialysis. But it's always wiser to use a form of RRT that the staff is familiar with. So please use the modality which you are familiar with, or if you are not available in the unit, the staff should be very much accustomed to the machines. Ultimately, after deciding, we come to the when to switch from CRRT. So switching to a shorter or intermittent RRT can be done once the patient is hemodynamically stable. We can go, if we have started with CRRT, we can shift to intermittent hemodialysis or SLED once the hemodynamic stability is there, or there is negligible inotropic support, which we can continue with the SLED. So no specific guidance can be provided, but we can have simple discontinuation, or if the we can have change in modality, frequency, or duration of RRT, or we can switch from CRRT to SLED, or directly from CRRT to intermittent hemodialysis also, and or we can decrease the frequency of CRRT. When we shift from CRRT to SLED, we can decrease the frequency of SLED from daily to alternate day or every third day. So this is as per the clinical condition of the patient. So when to stop RRT? Clear-cut guidelines are not there, but I-CCSN guidelines, they do suggest that we can stop RRT if we have a urine output of at least more than 400 mils per day and a urine creatinine clearance of more than 15 to 20 mils per minute. Also suggested are that if there is improvement in intrinsic kidney function to meet the demands, and in case of futility, we feel that RRT is not going to help the patient in any way, we can take a decision to stop RRT. Although as of now, use of biomarkers, there are many studies which show that cystatin C or NGAL can be used, but no substantial guidelines have come up. Let's see what the KDIGO is coming up with the recent guidelines. So what they suggest, I'm also eager to look at it. So to sum up, if we compare the CRRT or peritoneal dialysis vis-a-vis the prolonged intermittent renal replacement therapy, which is a hybrid therapy, or to IHD, IHD has rapid removal of fluid, rapid clearance of the solutes, acid-base correction is much rapid, but associated with risks of osmolar shifts and lots of hemodynamic instability. So if we are targeting rapid removal of fluids or solutes, and so IHD is a better modality, but CRRT, we have better hemodynamic stability, stability of the intracranial pressures, but certainly the risk of immobilization, the initial cost of CRRT is very high. So we can have a intermittent, the hybrid therapy, which can take the advantages of both, and we can go with. So this is all about how we decide about which modalities to select. So thereby no difference, but yes, the clinical situation we are dealing with, wherein what we are targeting to remove. So we decide the renal replacement therapy accordingly. But ultimately, we ought to remember that the renal outcomes are much better with CRRT. So if at all we have the CRRT machines available, and if the patient can afford the initial cost, so this should be the preferred modality for our routine renal replacement therapies, especially for the ICU population. So with this, I think this is a race between the Ferrari versus the Rolls-Royce. It doesn't matter. I can't say which one is better. So it's just behind the machine, who's sitting behind the machine, who decides, and that will where the preference will matter. So with this, I would like all of you, please, you can go and read these I-CCSN guidelines on acute kidney injury and renal replacement therapy, which we published around 4 years back. And I think this comprises of lots of issues, especially the technical aspects of RRT, which we have not discussed, because in 40 minutes, I thought, firstly, we ought to decide how to decide which patient needs which type of renal replacement therapy. That is the first decision we should always have. So I started with that, but the technical aspects, especially the hardware and the prescription of RRT, is another, we can have another session if at all you all feel. And with this, I would like to thank you, and I welcome you all to Criticare 2027 happening in Agra, the city of Taj, India, in the month of February, from 18 to 21st February. So we all will be eager to have you here for Criticare 2027. Thank you so much.
Thank you, Dr. Sodhi, for this wonderful lecture. I, for one, have learned a lot, and I'm sure all our participants too, they are learning just like I am learning. We have 4 questions already in the chat box. Number 1, thank you all for joining. Please drop your questions and comment. That's clear, which is from us. I think I'll take my first. He said, we will appreciate this isn't clear. Okay, my question for you, Dr. Sodhi, is concerning the continuous venous hemofiltration. Are there special features for septic patients that will remove toxins? You know, because what I have seen, we have CRRT machine in our ICU. Most times, the filters they give us, they said they are not the filters that will remove the toxins. So I think you should throw more light on specific filters and for specific purposes.
So herein, for the sepsis patients, we can have a high volume hemofiltration. One thing is high volume hemofiltration, or we can have the specific filters like Oxiris or the Cytosorb. Oxiris filters, I don't know what all filters are available with you, because Oxiris is only for the Baxter machines, which removes all the cytokines and the immunomodulators, and along with it can also act as a renal replacement therapy filter itself, the dialysis filter itself. But we can attach the cytosorbs, which primarily removes only the cytokines and the immunomodulators, but it does not clear the solutes. So we can have the cytokine filters, or we can have even these polymyxin filters, which also are good for removing the cytokines. So different types of filters, but none of the filters have shown any advantage in the survival. Survival benefits have not been shown in any of the studies. What the most of the studies have shown is that the hemodynamic optimization is much better in patients with sepsis, because the vasopressor requirement decreases by 24 hours or 48 hours, and no survival benefit has been shown. Even the latest Tigris trial, which came up just 2 months back, it again showed no survival benefit. But we can have high volume hemofiltration, wherein we target a higher volume, instead of 25 to 35 ml per minute, we can have up to 50 to 75 ml per kg per minute. So that we can target. But again, that has also not shown high volume hemofiltration as compared to in Ivor's trial. High volume hemofiltration vis-a-vis normal volume hemofiltration, it did not show any benefit at all.
Okay. Thank you, Dr. Sodhi. Are there questions for the speaker, please? It is time for questions and answers. If you have your questions now, you can raise your hand.
There are two questions in the chat box.
Yes, I can see.
Yes, please, did you also consider the rapidly acidotic patient with low pH and low bicarbonate? Which modality is preferred?
Okay, thank you, Dr. Job, for this question. This is a very relevant question, especially for our population. So certainly, if we are targeting a patient who has a very low pH, rapidly acidotic, if we want to have a rapid clearance, we will start with intermittent hemodialysis. But for this population, if we are targeting the toxins, we do prefer that we go in for intermittent hemodialysis. But lower pH and lower bicarbonate acidotic patient, we can start with continuous veno-venous hemodialysis, and it does not achieve so rapid clearance, but certainly the acidosis improvement will be much better with CRRT. So we do prefer, for our population, I do always want to start with a continuous veno-venous hemodialysis or hemodiafiltration.
Thank you. There's another question here. It said CRRT is expensive. For hemodynamically unstable situations, is lead feasible at a lower than 150 ml per minute?
Yes, we can go, but most of the machines there are different types of machines we can use the routine machines for intermittent hemodialysis, which usually do not go below 200 mils per minute. But there are machines like the Fresenius 4008 and 5008. They do go with lower blood flow rates, and we can go up to 120 mils per minute. But routinely, even as I actually stressed upon, that only the blood flow rates do not matter. What matters is the ultrafiltration rate set in the especially if we want to have a more hemodynamic stability, we can actually have higher sodium dialysate fluids, and we can come down with temperatures, rather than, because even we routinely do a sled at around 150 to 180 mils per minute. That is the blood flow rate we usually routinely keep, and even we go up to 220 also. So it does not cause major hemodynamic instability. But initially, when we start with a sled, what we can do is we can keep supposedly we target a blood flow rate of 150 mils per minute. We can have zero ultrafiltration rate, and further as the patient becomes bit better, we can target set with the this ultrafiltration rates. And also the timings. Supposedly we started with 8 hours of modality. So we can go up to 12 hours. If we increase the prescription time, that itself can also lead to better hemodynamic stability.
Thank you, Dr. Sodhi. Hope that question is cleared. The person who asked the question. Thank you, Ma. There's another question here. Patients with renal failure who have satisfied the criteria to discontinue, as you highlighted, but patients still continue having severe anemia. What is the approach?
So severe anemia is basically RRT is never to treat the anemia. Anemia is because of the renal failure per se. So we cannot combine both these things together. The anemia has to be differently targeted. So we can go in for erythropoietin, which we routinely do for all our CKD patients. So, but routinely for acute kidney injury, we do not see anemia of chronic kidney disease. That we have to be very clear. So if our AKI population is having anemia, so we have to look in for other causes why this patient has anemia. So we ought to look for the cause and treat accordingly. Or for the patients who have acute on chronic kidney disease, we can go in for erythropoietin. But RRT per se has no connection with the anemia.
Thank you, Dr. Sodhi. The next question. Thanks for the presentation. What is your view with the use of bicarbonate infusion in septic patients with low pH and bicarb as low as less than 40 to 50 millimoles per liter? That septic patients with low pH and low bicarbonate. What is your view with the use of
Yeah.
bicarbonate
This,
infusion?
this is one question I'm very much obsessed with, actually, because as of now, what we have, the guidelines or whatsoever the position statements say is that we ought not to use bicarbonate if the pH is more than 7.2 and the bicarbonates per se are more than standard bicarbonate is more than 15. So this is the standard protocol. But right now, I think very soon even the BICAR study says this. BICAR 2 just came last year. So this again says that there is no benefit of giving bicarbonate at a pH of more than 7.2 or bicarbonates of less than more than 15. But we are coming up with another study that is the I'm just waiting. There's a multinational study, SODA-BIC study, wherein we studied the bicarbonate use in mild acidosis. So we always talk about the severe acidosis. So mild to moderate acidosis, we have kept the pH as 7.3. That is the cutoff. So let's see, the results are awaited and I'm also looking forward to. But as of now, the pH of less than 7.2 and bicarbonates of less than 15, that is the only indication for starting bicarbonate therapy. Otherwise, we do not give bicarbonates.
Thank you, Dr. Sodhi. The next question is, okay. The question is, thanks for this wonderful opportunity to be a participant. It's actually this person is actually commending you and thanking you for this presentation. So the question is, how much volume of fluid can we give patients on dialysis to avoid volume overload? Is it calculated based on urine output or dialysis feed rate?
So certainly, when we are talking about renal replacement therapy, we ought to have minute, looking into the minute details like about the fluid loads. So we ought to forget the creeping fluid. We ought to forget what all we are giving with the nutrition, with the antibiotics, all those things we want to keep in mind. So thereby CRRT, wherein we can, fiddle with the machine every hour. So previous hour, what is the urine output, how much intake it is, and how much output, what ultrafiltrate we have set. So we can just fiddle with the machine and have optimum fluid management. Because supposedly we gave 2 antibiotics in 200 mils of fluid, and we gave renal RT feed of 200 mils in the last hour. But what we have set is ultrafiltrate of supposedly 300 mils. So effectively, we are into a positive balance. So we have to look not only on the urine output or the filtrate, we have to, assimilate all the things together and thereby decide what ultrafiltrate and how much we want to remove from the body. So all these things, this is when we can have another session on the prescription and how we go ahead with the technical details of the CRRT. So therein it is better, I can explain in a better way, but we cannot have single parameter that we are only looking at the urine output, and most of the times our AKI population is actually anuric. So patient will not have any urine output on. So if patient is not having any urine output, so we cannot, base our volume ultrafiltrate on the urine output itself.
Thank you, Dr. Sodhi. So I think we've asked all the questions. Okay. So there's one question here too. It said, septic patients with normal central venous pressure and elevated lactates, even after hemodialysis, what else can be done because the pH continue to be low?
So one thing we always ought to remember is lactate is not cleared by renal replacement therapy. For lactates, we have to focus on what is the primary issue, why the lactate is rising. If there's hypoperfusion, we have to correct it. If there are issues with the liver, we ought to look into it. Or if there's mesenteric ischemia, we ought to look into it. So lactates are never cleared by the renal replacement therapy. So we cannot do much about lactates, but beyond lactates, if there is the bicarbonates are low, or then the pH can be corrected. But for lactates, we cannot have the this RRT. We cannot attribute lactates only to renal replacement therapy. So for correction of pH, yes, we can go in for, as we have discussed, we can go in for bicarbonates, bicarbonate therapy, or we can continue with the renal replacement therapy for correction of acidosis. So that is a choice how long we need to continue with the renal replacement therapy. But for lactates, we cannot target the RRT.
Thank you, Dr. Sodhi. The next question here is, what is your take on fluid management for a patient who is still hypotensive on ionotropes with vasopressors? Nephrology says he has acute tubular necrosis and is limiting the fluid per day to 500 ml, but the lactate is high, although the patient is anuric. How do we manage this?
So first of all, for this patient, this is again a practical reality we face during our ICU rounds. But we ought to need to look into, like, what is the cause for this ATN. One thing is we might be having only hypovolemic, because once the nephrologist sees a anuric patient, he just starts limiting the fluids. It is because what they routinely deal with are the CKD patients, wherein they restrict the amount of fluid to be given. So our patient in our like if we have sepsis associated AKI, so septic AKI itself, it might be just because of hypovolemia. So we need to look into the fluid status of the patient using all the dynamic parameters, whatsoever availability is there. We can use the IVC collapsibility, or we can go in for PLR simply. We can go in for passive lag raising test or other dynamic parameters, and we need to look into, like, what is the fluid status of our patient, and thereby manage. If our anuric patient, doesn't mean we are not going to give fluid. If anuria is because of hypovolemia itself, it will further create issues with the same problem. So we ought to look for what is the cause for anuria and thereby decide with fluid management.
Thank you, Dr. Sodhi.
And
I think we're done with it. Yeah.
Hypotension itself doesn't mean that patient is, so if patient is hypotense, patient is in shock on vasopressors. So even if we just give fluids, patient might improve. So anuria also can improve. And routinely we do see that once we optimize the fluid status of the patient starts pouring out urine.
Okay. It said the antibiotics and renal replacement therapy. What is the best time to administer them in patients on dialysis?
So this is another complete, session wherein we talk about antibiotics and RRT. So what we ought to know is that not all antibiotics they're cleared by, but which antibiotics are cleared by the renal replacement therapy. Mostly the beta lactams, they're all removed by the this renal replacement therapy. So we need to give loading doses of beta lactams, especially post dialysis. And we should always have another important thing when we talk about antibiotics and RRTs. We always should give the loading dose, because loading dose of RRT is for loading dose of antibiotic is to achieve the concentration in the blood. And once we have an adequate concentration, so this should be a rapid achieving the rapid antibiotic levels in the blood. So always, even in patients on with AKI, we should always give a loading dose. And you routinely, this is a complex thing actually, but after SLED, routinely we do give a loading dose of the even the beta lactams. Vancomycin also needs a loading dose to be given, but because they are routinely cleared with renal replacement therapy. And the dose modifications are as per the recommendations, but no clarity is there. We just did recently, I think we are yet to publish that. We did a survey based thing, that how people modify the doses. So we ought to know which drugs are primarily removed by the dialysis. There are the low molecular weight substances which are routinely fluid soluble, water soluble drugs, and having low molecular weights, low volume of distribution. So they all tend to be removed, and they are the drugs which do need a loading dose even after every session of dialysis.
Thank you, Dr. Sodhi. Somebody's here. Please, ma, what is your view on the use of polymyxin B in renally impaired patients?
So polymyxin B, yes. When we compare polymyxin B versus polymyxin E, polymyxin B is said to be more nephrostable. Many studies have compared that the renal toxicity is much less with polymyxin B. But again, we need to give a loading dose of polymyxin B up to 15 lakhs per unit as a loading dose, and thereafter we can use up to 5 lakhs twice a day. That is routinely said to be safe.
Thank you, Dr. Sodhi. Are there more questions, please? Okay, on the same issue of antibiotics, should we give higher doses because of the renal clearance? Example, meropenem, 1 gram, 3 times daily, as opposed 500 milligrams 3 times daily for AKI, not on intermittent dialysis.
Yes, augmented renal clearance, we should always keep in mind patients who are in AKI, even anuric patients. We do give the routine doses, the meropenem 1 gram thrice a day. That is the routine, even for patients who are anuric. So even if we go, the KDIGO just released last month, they released the AKI guidelines as a public view, wherein we are open to give the comments for the guidelines. They also recommend that the doses in AKI, drug doses in AKI, should not be based upon creatinine only. So we ought to keep in mind the augmented renal clearance. So we are certainly justified giving higher doses with augmented renal clearance, which happens in AKI.
Okay. So what is your view, ma, on ulinastatins? What is your advice?
Ulinastatin, yes, if I talk about 10, 12 years back, I have used it as but as of now, as what the stand as of today's date stands, there is no role of ulinastatin. As a septic modulator, it has been said we have used in acute pancreatitis, even we have used in paraquat poisonings, but certainly no role as per the literature. They say the ulinastatin is just adding to the cost. So as of now, we are not using currently. For last 5 years, I have never used ulinastatin.
Okay. Thank you, Dr. Sodhi. I said, thank you for your beautiful presentation. I am still a bit confused about your stand on the use of intermittent hemodialysis in hemodynamically unstable patients, especially in the absence of CRRT.
Ramigus, don't be confused. So I'll try to sort out your confusion. If the patient is hemodynamically unstable and you don't have a CRRT machine, rather than using intermittent hemodialysis, go for SLED. SLED means you can decrease on the blood flow rates on your routine machine. You can increase the time, prescription time. It can be the RRT timings will increase from 4 hours to 8 hours, and use a higher dialysate sodium levels, so you can achieve the same amount of hemodynamic stability as is seen in the CRRT. So don't get confused, but yes, just fiddle with the machine. And when you start with SLED, just don't start with any ultrafiltration for the initial half hour or so.
Thank you, Dr. Sodhi, for the questions you're answering. Yes. Thank you very much, Ma. Are there questions in the house now? I think we're done with the questions in the chat box. If you have questions for the presenter, how much time do we have so that we know how far we have to go?
Probably we can spare 5 minutes if there are questions. Otherwise, we just move to the vote of thanks.
Okay.
For any further questions, I have just put in my email in the chat box. So anybody is open. I can have questions on the
am I audible, please?
WhatsApp number, and you can just contact me on my WhatsApp number also.
Okay. Thank you very much. You are audible.
Hello, am I audible?
Yes, you are audible. Dr. Abiodun, you are audible.
Okay. Dr. Edionhon.
Yes, we're waiting for the other person who want to say something. I want to thank you, Dr. Sodhi. That is a fantastic one. You've seen how many questions your lecture has created. It shows that we still have a long time to go. We still have to have a time to maybe create another platform where we can have a one-on-one discussion of clinical scenarios with you. Because CRT is quite expensive. I don't think many hospitals in Nigeria have it. So how do we modify the normal intermittent hemodialysis machine, the regular dialysis machine, at a lower flow rate, blood flow rate to create what looks like a SLED? That is the part that is a little bit. Somebody said yes, it's feasible. But if it's feasible, we have more intermittent hemodialysis machines in Nigeria than we have here. So we don't know how feasible it is. Because most of the technicians don't want to go beyond 4 hours. But do you have any experience with that?
Dr. Sodhi, that's for you. That question is for you.
I can't, I couldn't hear any voice. I just put in the chat box also. If you can just come up with the question again, I'm happy to answer.
Mr. President, sir.
The voice was breaking actually.
Well, okay. Can you hear me now?
Yes, sir. I can.
Can anyone hear me? Is it clear? Is it audible?
Yes, we can hear you.
Yes, the question I have is this. We have the more regular dialysis machines in Nigeria than we have because of
I'm sorry, sir, your voice is breaking.
Yeah. So what time?
Your voice is breaking. If you can just put in the chat box.
Hello, hello, can you hear me?
Hold on, sir. Hold on. I'm hearing you. Maybe my network could be better. Let me put the question to her. Dr. Sodhi.
Yes.
The president is saying that CRRT is very expensive, and we don't have it in most hospitals in Nigeria. That in the absence of CRRT, what do we do with our regular dialysis machine so that we can still offer to patients, in place of CRRT? I think I
So,
got that clear,
yes,
President.
yes. So, here in the slide is the answer. So, we can do the slide. The major advantage of slide is that we can use the routine hemodialysis machines. We can just go with the slower blood flow rates, right? If like for intermittent hemodialysis, we have the blood flow rates of 300 to 500 mils per minute. That is routinely, we routinely keep around 400 mils per minute, but we can go down to up to 150 to 200 mils per minute with the blood flow rate. We can decrease the dialysate flow rate, and we can increase the time, the duration of therapy from 4 hours to 8 hours. And we can achieve we almost 70%, even in Indian settings, 70% of the ICUs, they routinely use SLED because CRRT is a costly uh, uh, therapy. So I do understand, but more recently, the peritoneal dialysis, we can always try. It is a very simple thing. Just put in a peritoneal catheter. The Tenkov catheter is available, and we can use a cycler and set the the dwell time and achieve good hemodynamics and good solute removal with peritoneal dialysis also. But it is very easy, sir. If we start with, if all of you, I can have another session wherein I can let you know how we routinely change the settings of the intermittent hemodialysis to the to go in for SLED. So we can just fiddle with the machine, and we can have very good hemodynamics and very good solute clearance in our routine patients who are hemodynamically unstable.
Thank you, Dr. Sodhi. Dr. Ezogowa. Yes, you can ask your question. Your hand is up.
Yes, thank you so much. And thank you, Dr. Sodhi, for the beautiful presentation. I think I just wanted to make a comment on the slide. I think one of the problems we have is the technical know-how. I think maybe we need more training on the use of SLED. And sometimes many nephrologists are not so convinced that SLED can be close to or to CRLT. And nephrologists are usually, quite, should I say, anxious or reluctant to consider SLED. I think one of the things is we're not sure of the technical know-how of our nurses or those that are doing the dialysis to handle SLED appropriately. And then sometimes because of the number of patients, the patient load, keeping one patient on one machine for over 8 to 16 hours becomes a luxury that we may not be able to afford sometimes. I think so. These are some of the challenges we have to overcome in the use of SLED. But thank you so much for the presentation.
Yes, I agree. SLED is actually a very good modality, and I think the more you start using SLED instead of routine intermittent hemodialysis, the more experts you will become. And obviously, the nephrologist will be always happy to go in for it. And moreover, if we start with a 8-hour SLED and we have not achieved adequate acidosis or the solute removal, the acidosis has not been controlled. What we routinely do is before the end of the session, a half hour before, we get a blood gas done, and then we extend further SLED for maybe 4 hours or 8 hours further. And then we do have sessions of up to 16 hours of SLED ongoing. And the routine machines, they are very good for not only the Fresenius, these 4008 and 5008. I don't know which machines are available in Nigeria, but almost with any IHD machine, you can go in for SLED because you have to just fiddle with the technical details.
Thank you, Dr. Sodhi. Presido, your hand is up. You can ask your question, sir. Dr. Tokola. Dr. Josa, your hand is up. You can ask your question.
Or you think it's an old hand? We need to
Okay.
start rounding up.
Okay. Thank you very much, Dr. Sodhi, for this wonderful presentation. I have learned a lot, and we are hoping to have you soon so that we have a clinical scenario. We discuss patients and benefits. Thank you so much. So I'll hand over to you, Presido. Dr. Irene, please.
Yeah. Okay. Thank you so much, our moderator, Dr. Kate Edionhon, for such a wonderful moderation. To our speaker, Dr. Kanwal Sodhi, thank you so much for accepting to do this presentation. We understand the time difference. It's almost 10 p.m. or past 10 p.m. actually, getting to 11 p.m. where you are in India, and this just shows how much knowledge sharing and how passionate you are in this aspect of critical care medicine. I would like to recognize the presence of the past president of the Nigerian Society of Anesthetists, Professor Elizabeth Obulunwaso, past president of the I-CCSN, Professor General Shino Obashino Ogumbi MNI, and the immediate past president of the society, Professor Babatunde Oshinaike. At this, and we really had a lot of persons joining us from India and from outside the country, our colleagues in the UAE and Saudi Arabia and other countries outside Nigeria. Thank you so much for joining in. At this point, I will hand over to the PRO of the society, Dr. Jedoi, who will give a better vote of thanks and continue the last aspect of the webinar. Thank you very much. Dr. Jedoi, over to you.
Good evening, ma'am. I hope I'm audible.
Yes, sir, you are.
You are.
Okay. Thank you very much, Dr. Thank you very much for a wonderful presentation. On behalf of the president and the executive officer of the Intensive and Critical Care Society of Nigeria and all the members, I want to appreciate you for your time and for actually your intellectual disposition on this matter. We appreciate you. And we hope that when next we call on you, you'll be willing to allow us to drink more from your wealth of knowledge. Also, we want to especially use this opportunity to invite you to our scientific conference that is coming up August this year. That is coming up in July this year. Sorry, between 8th and 10th of July this year. We are hoping that I will be expecting you there. Am I audible?
Yes,
Yes,
you are.
Okay. Okay, thank you very much. I also want to implore everybody that's yet to register for the scientific conference to please let us register so that we'll all meet in the conference and share knowledge. I'm posting series of posters that is trying to show us what is going to be happening in the conference. We are expecting us to submit our abstracts, which we end by the 12th of June. The guideline for the abstract submission has been posted. We are still expecting our abstracts. Also, the inaugural lecture, Professor Obashino Ogumbiyi inaugural lecture is also going to be coming up, and the topic is oxygen as a lifeline, building resilient critical care system in Nigeria. We can also see the poster. Also, the workshop, it's also on. I've posted the poster. It's include the basic life support course and also the basic echocardiography hands-on workshop. We are all employed to register so that we can all attend the program. Thank you very much. I'll be handing over back to the VP. Thank you.
Thank you so much, Dr. Jide. Before I hand over to Mr. President, I'd also like to recognize the presence of the chairman, Faculty of Anesthesia, West African College of Surgeons, our elder, Professor Fola Papunde. Thank you, Mark, for joining. I would hand over now to Mr. President of I-CCSN, Dr. Job Otokwala, to do the concluding formalities. Thank you very much. I don't know, sorry, before Mr. President joins, I don't know if our past presidents, Professor Ugumbi, would want to say a word, or Professor Nwosu, or Professor Shinaike would want to say a word. Otherwise, Mr.
Thank
President will
you
give.
very much, Moderator, Dr. Kate, for asking us to say one or two things. I want to say a big thank you to Dr. Sodhi, who has eloquently and lucidly made this presentation. And she has tried as much as possible to enlighten us on gray areas, especially in our own climb, in terms of challenges we do have with respect to CRT. And I think for this kind of webinar, it's a very, very good one coming from I-CCSN, and having a round peg in a round hole deliver it is awesome. So again, I thank the organizers, and I believe all of us participants, we have made one, we have been able to achieve one or two things in terms of knowledge in this area today. I thank you all. God bless. Over.
Thank you very much, sir.
Okay.
Thank you for the opportunity for call and the recognition. I stand on the existing protocol. I want to appreciate the I-CCSN, the executive, and all the organizers of this excellent webinar. I really appreciate Dr. Sodhi because she went into details in this area of discussion. So, Dr. Sodhi, thank you so much for giving us so much from your wealth of experience and knowledge. It's really been a great time. I'm hoping that with good arrangement with the organizers, we can have your slides so that we can further study the topic. Thank you so much and greetings.
Thank you.
Thank you. Just to say, the slides will be available on our website once we get them from
Sure,
the business.
I'll be happy to give.
Oh, thank you.
Thank you.
I think we will. Thank you very much, ma'am. Sorry, Professor Oshinaike, can we conclude? I don't know if he's still with us. So we can. Mr. President, Dr. Joe, I think he went out. Well, on behalf of Mr. President, Dr. Joe Otokwala, members of the Executive Committee, BOT, and members of I-CCSN, I wish to sincerely thank our presenter today, our 29th webinar series on renal replacement therapy in the ICU, for giving us her time and her knowledge and practical, a very, very practical lecture. The dynamics with Nigeria and India, of course, come to play, and we can perceive, and we felt the practical, how much practicability this lecture relates to us in Nigeria. So thank you so much for this, and we believe this will improve the relationships and strengthen the relationship between the I-CCSN and the Indian Society of Critical Care Medicine. I want to thank you all for spending about an hour, 30 minutes with us your Sunday evening, and we do not take it for granted. Displayed on your screen is our conference in Abuja 2026 from the 6th to 9th of July. It's an annual scientific conference and general meeting. Information is on our website. Please take time to register, send in your abstracts. Every single thing you do in ICU is worth sending in as an abstract. So we await your abstracts, and we look forward to having you all join, not virtually, physically. We would appreciate you all joining us in Abuja. For members joining us from diaspora, please, you can also send in your abstracts, friends of I-CCSN from other countries. Please send in your abstracts, and it would be nice to share knowledge. Thank you once again for joining, and enjoy the rest of your evening and have a lovely week ahead. Thank you once again, Dr. Kanwal. Thank you, Dr. Edionhon, the moderator, for making this session very interesting. Thank you and have a good night rest.
Thank you so much. Thank you. I'll like to thank Intensive Critical Care Society of Nigeria for having me here. And I hope you go back wiser, and I'll be always happy to interact. We have a ISCCM online Fundamentals of Renal Support course also, for which I'm the coordinator. And if at all anybody wants to go into the intricacies of renal replacement therapy, you all can go to the ISCCM website and look for that. And if at all anybody is eager to join, you're most welcome. Thank you so much, and good night, everyone. Thank you, sir.
Thank you so
And
much.
thank you,
Thank
Aaron.
you.
Thank you, Kate.
Yes.
And thank you, Mr.
Yeah.
President.
We've
Good night.
taken up this your offer. The I-CCSN will work with you behind the scene to see how we can get our members interested and work the logistics out.
Yeah,
Thank you
sure.
very much.
Thank you. Good night.
Yeah. Good night, everyone. Bye. Thank you.
Thank you. Good night.
Good night,
Thank you.
everyone. Thank you for joining. Bye.
Good night.
Bye.
Goodbye.
Thank you. Thank
Bye
you.
bye, Vice President, President, and all the elders in the house. Bye bye.
Yes. Thank you so
Bye.
much,
Thank
everyone,
you,
for joining. Bye.
Dr. Irene. Well done.
Thank you so much, General, sir.